Hello and welcome back to Handover with Dorky Docs, the podcast where we talk about the different communication barriers between medical specialties and the MDT. This week's episode, we've got Dr Joel McKay. He's a haematology registrar in London, but alongside that, he's also works alongside Melio, a diagnostic and health service, and also works as an editor for the MRCP Part 1 question bank. And if that wasn't enough, a couple of years ago, Joel was also on Tipping Point, the award-winning show on ITV, and came out as a winner. So, thank you for joining me today, Joel.
No problem. Thanks for having me.
No worries.
Very, very successful time of my life, winning £5,000 from Ben Shepherd on ITV. So
it's better than most days at work, I'd imagine. So, you've obviously got quite a portfolio of a career there. Was that all planned? How did you get into sort of making a mix and match of sort of doing clinical work and other things alongside that?
So, a lot of it started from a bit of trial and error. It wasn't the intention. My intention was always, as everyone does, they go through med school. At some point, they want to be a cardiothoracic surgeon for a week. And then they think, no, that's ridiculous. I'm not going to do that. The hours are horrendous. But my intention has always been to be a hospital doctor, so a medic. And it just came about that me speaking to some friends who were then a bit further ahead in their training of me, who were doing some private work as sort of medical locums at Harley Street and those kind of things. And I just got speaking to some clinics and they were advertising different jobs and different roles. So my role was in Melio. And then with the BMJ, I was literally replying to a question that I thought was a bit rubbish. With all those comment sections and someone's moaning about it. And I put something about, I think this guideline is outdated. And then the sort of head of editorial, a guy called Jared, got back to me and said, would you like to do some editorial work for us?
Okay, so it's basically taking most of the opportunities, right?
Yeah, it was all a bit of, chance and trial and error. And I just thought, if you don't ask the questions, you're never going to get some answers or even, what's around the corner.
Yeah, definitely. How do you balance that all in terms of your working week? So what does your working week look like? How do you balance it?
So since becoming a registrar 2-3 years ago, it was pretty hectic. I was working at a large teaching hospital in London as a haematologist. And I'm not going to lie, the first 6 months I absolutely hated being reg. Thought I don't want to be a decision maker. This is terrible. And at the same time I've got to do 16 hours a month of BMJ, whenever that may be. So doing weekends. And then I was doing 8 hours of Melio a week. So quite a lot to fit in. So I took the decision, I thought I'm going to go less than full time. And I've gone to 80%. So my week is now Monday, Tuesday, Wednesday is clinical work. Thursday I have off.
Yeah.
A day like today, you can go for a run in the morning and have non-clinical work. And then obviously I'm in Friday and I've got to fit around my on-call rota. But the big decision was to go less than full time. And I think in the NHS, if I'm quite honest, I think there is a reputation sometimes amongst less than full-time trainees as, oh, you're less than full-time, you don't really understand how busy the week is.
Yeah, definitely.
I was probably one of those people to go, oh, they're only 60%. But it's the best thing I've ever made. And I think everyone should consider it.
Do you think it was harder because you're a male?
I had no excuse to go less than full time, really. There's people who are 60% who are on mat leave and quite rightly they're working nearly 25 hours a day with their children, basically. I didn't think it was harder because I had a very supportive TPD, one called Magda Sohal, who's a haematologist. And she was very positive about people taking time out of training. And she says, I'd rather all of my registrars finish their training over 10 years and have no dropouts than 70% finish over 5 years.
It's important to have that sort of role model to sort of balance that sort of stuff out with. I didn't phrase that question in a sexist way. The reason I asked that is because, if you don't mind me saying, it's not very common for males to take a training position less than full-time, be it 50%, 80%, whatever it is. And I know in some places, particularly where I've looked at previously, it's almost frowned upon. But
yeah, people often ask me, do I have children? I don't.
That's the first question, isn't it?
Yeah. And my partner works. She works full time. She's a nurse.
Yeah.
But the person I spoke to was another male registrar, and he said, even though I do have children, it's they still go to daycare on the day I'm off, and I have a day for my own reflection and to do something outside of medicine that things like get a haircut, which it seems really trivial, or like go to the bank to sort me out. But there just isn't the time, is there, if you're full time?
Yeah, because most people end up doing it on their rotated off days after nights or something stupid like that.
Yeah, and you've sat in a barber for an hour and a half when you've had to sleep and you're tired, and
Do you consider your off days off days?
My partner certainly does. She says, "Oh, you can walk the dog today. We've got to take stuff to the dump, so you can do that." I consider them half days, and I consider them almost like a recharge to go back on Friday to work, and you feel like you're ready to tackle the day again. So they are a recharge, but equally, my hours are not defined. I don't have to do 9 to 5. I could, on the tube to work, do all my hours and then have my Thursday off. So yeah, I don't consider them as off days per se, but they're kind of like a half day, I think.
Fair enough. Tell me more about Melio. So what's your sort of role with that?
So Melio they're essentially a blood testing company and a health check company for people who, as I'm sure as a GP you may get this a lot, but people who want to just, I'm 30 now and I'm getting old, and things like diet and exercise, you have to make more of a conscious effort. And you may see, macro results, and you may have lost a bit of weight, or you may have stopped, going out and drinking on a Friday night with your friends. But actually to see linear change over things like my LDL has gone from 43 and I'm 44, so I no longer need a statin, I think is something we don't do well in Britain. So I met them through my partner's working in Harley Street. There was a clinic, and they were doing bloods in this clinic with this company. I just got talking to them, and it was something I was really interested in. The people I work with are all NHS doctors, but all have specialist interests in certain things. So we have a sports and exercise consultant, we have an endocrinologist, we have a psychiatrist, we have a GP. So it's a nice MDT, and for something that actually is not very expensive, and you can do maybe once or twice a year, you can either reassure yourself that things are okay, or you can say, well, actually, I have put a bit of weight on, and that's reflected in my HbA1c, which has gone up from 6 months ago.
Mm-hmm.
And it's a little bit like, why would you wait for your car to break down if there's a warning light?
Yeah.
Why wouldn't you take it to the mechanic first? So,
what has working for Melio done for you as a doctor? And I mean that in terms of, you're obviously in a training program in London doing your haematology stuff. What skills have you learned from that? You can say, you know what, I'm going to bring that into my NHS career.
I would say the first couple of skills I've learned: speak your opinion, and don't be afraid to offend people. And that actually you might not know everything about a subject, but you're employed there as a doctor or a nurse or a CNS or a physio or whatever. You're employed there as a professional to give a professional opinion. It might not be right, but you need to have an opinion that's based on evidence, knowledge, and what you think from your experience. And I think sometimes in the NHS it's very hierarchical. There's a consultant, they are the boss, they must be right. But actually you may be more au fait with a certain guideline, or you may have seen something, I don't know, in an elective that you think, I'd like to offer that. I think people are, especially junior doctors, are afraid sometimes to offer up that opinion. And at Melio, there's a platform where you have daily meetings, you have regular Zoom meetings, and you're always encouraged to speak your mind if you're not happy with something.
I guess what I was trying to find out was what sort of drew you to that? What drew you to the sort of finding something outside of your traditional, conventional, linear sort of pathway?
One of the main motivators was, how can I work less in the NHS on a week-by-week basis, but still sustain, with matter hierarchy of needs, my main things I need, like mortgage, food and water, the ability to spend money on whatever. And I think within the NHS, when you look at the less than full-time pay, it's not significant, not too significant. And you think, actually, what else could I do outside of work in those hours? I know we spoke before, but if I'm paid by the hour, or if I am paid for something rather than just a block payment, that was a big driver for me. Was, what else can I do that's slightly different, that I still really enjoy, but means that I have more autonomy and control over my work? And I think that's the thing. There is, when you become a reg, or even when you're a CMT or an F1, you have no autonomy over your day. It's 9 to 5, 9 to 9. For example, it's a gorgeous day. I was sat in the garden doing my work today at 8, 9 in the morning with a coffee. Like, it's crazy that you're able to do that and still enjoy your work and finish at 4 and go for a run or something. So that was my main thing, was quality of life and financial.
I find it interesting when you mention that, you don't have to go into details, but sort of getting paid for the time as opposed to getting a block payment for a salary for whatever, because I think, I don't know about you, and you're probably going to agree with me, but when you go through medical school, you're tunnel visioned, right? So, you go through your 5 or 6 years and you end up as an F1 and you're a doctor. It's fantastic. You get all the adulation. And then you do how many years as F1, F2, then you go into training, locum for a bit, do what you want, and then you end up in your middle grade and you're consultant. I think that's the pathway that most doctors start medical school with. Where along that pathway did you think, actually, I can still grow in a sort of straight line, but have shoots off on the side that can provide an income and also provide me with an enjoyment of, actually, I like doing my work? Because you speak to a whole bunch of junior doctors these days, regardless of whatever grade, and it's a massive disgruntlement. And it comes down to, whether they actually have autonomy in what they're doing. Where did you find that?
Yeah. I figured, so I was very run-of-the-mill, below-average medical student, I would say that. Like 9th decile or something horrendous. And it wasn't until I got into clinical work and I loved it and I was really good at it. Sorry to blow my own horn, but relative to my ranking at university to how I was doing at med school, at work, they didn't match up. And then about a year in, I was like, I still love this, but I'm knackered. I'm absolutely knackered. And I'd lost the adrenaline that most people have of that first year. And you realize, I'm still basically a medical student as an F2. I just have less money and washing to do. And at that, around F2, I did an F3 in London in a few jobs. And I thought, there's got to be there's so many other things that, you're a professional with a degree in medicine, and all of my friends at university were either humanitarians, mathematicians, just whatever, English, and they all ended up working at EY or Morgan Stanley, starting on 60k. And I thought, we have in effect a degree that's harder, probably worth more, but they're earning more than us. Where is the role for us in the private sector or doing something that's related to medicine, because you've got that skill base? So round about when I moved to London, I followed my F2 and I met up with some of these friends, and that was when that sort of, those branches started to sort of appear, and as it were, I reached out to some of these places and got some different work.
Okay. So what would you advise to sort of junior doctors who are in that position where they're thinking, you know what, I'm in CMT or IMT or whatever it is these days, and I like what I do, but it's not what I want to be doing 100% of my time in 5 years, because there is a sense that it's a big step to take. You have to be quite courageous to sort of take the leap, cross that canyon sort of, and say, actually, I'm going to start something on the side or explore my other avenues. What would you say to those kind of people?
So I would say, I think the first thing you should do is, if you are convinced you want to do medicine, you want to be in a specialty you love, you have to tolerate the worst parts of your specialty. So I have so many friends who've started CMT and then gone on to do, I quite like gastro, or I quite like respiratory, and got to SD7 and gone, I don't really like it that much. I don't want to be a consultant doing bronch lists. I like different aspects. I think the first thing is, be true to yourself. Don't just choose core medical training or core surgical because that's the best thing to do in inverted commas, or GP because you want an easy life, because that's just not true. GPs, my mother-in-law's GP, she, there's a whole different skill set, and there's a managerial skill set, and it's almost like working 24 hours a day, essentially. But what I would say is, when you want to try and explore these avenues, it's baby steps. A lot of the things that I did initially, I started writing questions for BMJ. I could still do that on my off day. I could still do that on the tube home. I know people may say, I have kids and other commitments as well. But, there is time in work. You can ask for study leave. People don't realize this. You can ask for personal study leave during your training to explore other avenues. And doing things. I've got a friend who was a medical advisor for a startup coffee company because they're working with a product. They needed someone to sign off on things. They're consuming something. Someone to sign off on, is this safe for consumption, all that kind of stuff. He did that for 3 weeks as an internship, and he's got his own startup company doing something else. I've as well, but it all starts with baby steps, and there is more a kind of, I think especially nowadays there's more an attitude to, if you take time out of training, it's actually another string to your bow. Whereas maybe 20 years ago it was, why have they taken 3 years out?
I wouldn't even say it's 20 years ago. I'd say it's within the last, when I was doing CMT and stuff, and other people wanted to do things outside of conventional. I did a postgraduate diploma in sort of sports and exercise medicine. I remember speaking to a couple of people who were medical trainees, and to take a year out to do it to take on their masters, they were sort of told, actually, no, get your training done first. It's service provision, all that sort of stuff.
Completely. And the other thing as well is, if you're in a deanery training role, speak to like your TPD about other, as you say, postgraduate diplomas. I did a postgraduate diploma in palliative care that was funded by the deanery. I'm doing one now in genomic medicine, which is funded by Health Education England at Imperial. These are expensive things which are funded if you're in training. So and you get study leave for them. So it's worth speaking to your TPD. Okay.
So one of the other sort of things that I just picked up on was, I don't know about you, but personally, I think every doctor should give their hand at doing something outside of their standard training. Whether that's sort of starting your own business or looking into a bit of private work or joining another sort of line of work. I think you'd probably agree with me, but you learn life skills that you don't get. We're academically bright people, but you leave 5 years of medical school and most people would be stumped if they had to apply for a mortgage, So I completely agree with you. I think, personally, just to add on to what you said, I think if there are opportunities there, I jump at them, because you don't know what they're going to lead to. And also training's not going to go away. People are very scared of sort of, I'm not going to get my training program. I want to be a consultant as soon as I qualify. There's no rush. There really isn't. You're going to be doing that 40 odd years of your life. I was just saying that. I'm sure but I did medicine before. I did geriatrics. I loved it. I like working with elderly people. I like doing the on-calls. I like doing the weekends. I love the adrenaline of, seeing sick patients. But generally speaking, for me, it wasn't conducive with a personal life. And I think a lot of other people would sort of marry up with that story as well. But coming over to general practice, it gives you the autonomy. I really like it. But just touching on sort of some of the stuff we were talking about before, if you're a partner in a general practice and you have your surgery, you, as you said, like your mother-in-law, you do have to know managerial skills. You do need to know business skills. We got taught through our sort of training scheme of probably twice in the 3 years of how to manage or look at practice accounts. That's a huge part of, of sort of running a business. And I think in medical school, I don't think many doctors would be too averse if there was a small dedication or a module for people to say, we're going to teach you entrepreneurial skills, we're going to teach you sort of business skills, or just sort of, I don't want to say life skills, because they're not that. They're sort of, actually, this is what work is going to be like on a day-to-day basis, as opposed to the finest pharmacology out there. So yeah, I completely agree with you in terms of sort of making sure you take the most of the opportunities and see what else is available.
I was going to say, doing things like, you can get started early, like being the rota coordinator for your SHOs is a little thing you can start. There are business meetings every week with X amount of managers, and they're all on Teams now, so you can ask to drop in. And as you say, learning little things about how a service is run, and things like referral processes and how those are funded. I think if you're considering general practice or even hospital medicine, is massively important. So just from an early age, just get going with them. Generally, I think they're pretty good.
Okay.
But I think what I would say is for GP trainees that are coming into medicine or coming into hematology, and I did feel for them when I was doing my CMT, because they often get used as, everyone gets used as fodder in CMT. But I think the important thing for GP trainees, you have to realize you're a GP trainee. You're training to be a GP consultant. And there's a lot of pressure on I think the CMTs sometimes do get favored over you in terms of going to clinics because they have to do that for their portfolio, but I'm sure GPs do as well. But I think the important thing I say is remember you're a GP trainee, and don't just become the skivvy who does the bloods or does the lists or the rubbish jobs. Use skills that are going to benefit you in your practice in future.
It's really reassuring to hear you say that, you're going to be a GP consultant, because you don't hear that often from a lot of people in the medical, in internal medicine anyway, and also in surgery as well. So being specific, let's say you're even not hematology, let's say anything medical. What are the key things that you would want your GP trainees to be taking away from that rotation?
Elderly care is going to be, and polypharmacy is going to be massive in your role, because I think it's like 75% of hospital admissions are over 70. So that's the thing I think would be really beneficial to you. The second thing I would say is, what procedures can I get involved with which will be useful for me in the future? So things like punch biopsies, any form of examination, which is a skill in itself that needs to be learned. So things like pelvic exams, which often we don't do much of in our sort of medical school rotations. If you're attached to O&G, it's a very useful skill that can really help a lot of people. From a hematology perspective, the things I think would be useful for a GP to know, we split everything in hematology into white cell, red cell, and clotting. So white cell, if I'm honest with you, I don't expect a GP to know too much. And I think because the worry is always cancer, right? When there's a high white cell or a low white cell. And those patients should be referred within a 2-week wait to a hematologist. And anyone who complains, say, this is just, then they're in hematology for the wrong reasons. The second thing I would say would be, if you're ordering clotting tests for whatever reason, or hemophilia screens, they are expensive. They're not always indicated. And I would much rather a 5-minute phone call than a 30-minute clinical consultation in 2 weeks. And then the third thing I would say to take away from your rotation would be basic understanding of very simple things like sickle cell trait versus sickle cell anemia, or especially working in London, I used to live in Brent, and there's a big population of thalassemias. So knowing the difference between an alpha thalassemia and a beta thalassemia is really, really important. And I think a lot of people will present with anemia query cause, and you can answer their questions very quickly by a quick understanding of the conditions and scan of the blood film, a blood count, sorry.
Yeah. I think from my side of things, and I'm guilty of this, regardless of my experience before, but I think we often get in the trap of requesting bloods, finding something that's we didn't expect, or it's come white cells of 20 for no apparent reason.
I don't mind that. The thing that bothers me is more A&E actually is we've done all this shotgun approach of investigations, and one of them has come back positive. And the classic one is an immunoglobulin has come back as 20 IgG. Yeah. And it's now myeloma. Well, no. We need the big thing for that. The take-home message I would say, that's my bugbear. Immunoglobulins, if it's polyclonal, poly I remember begins with a P. That's positive, so it's not myeloma. That's a good outcome. Monoclonal is menacing, begins with an M. That could be myeloma. So that's what I would say is the big take-home. If that's all you remember from this discussion, immunoglobulins fires me up no end. But you're right. There is we know all these things. Off to heme.
Yeah, I think we fall into that trap. Okay, so moving away from sort of GP trainees, you might get your consultants probably know the answer to this more than you, but you probably get a lot of referrals from us and a lot of communication from us. Is there anything you'd want, other than what you just mentioned, for us to say in terms of when we're referring patients, in terms of the workup? Or
if there is anemia and neutrophils are low or high, if there's lots of different lines of cells that are affected, just call us. 2-week wait as well, but I'd rather you phone. The second thing I'd say is massively important, but isn't always on the referral, is symptomatology. Why did they come in? Was it just a well woman and man check? Did they come in with B symptoms, lymph nodes that are palpable, weight loss? And the final thing I would say is, I know it's difficult with COVID, it's really tough. Try and examine the patient. And the only things I want to know are, have they got lymph nodes and is there a spleen? And that is massively important, because if I see a referral, lymphocytes benign, otherwise maybe a smoker, we're just going to refer them back in 6 months. If I see lymphocytes 9, palpable lymph nodes and the spleen and some weight loss, straight away I'm like, this person knows exactly what they're looking for. And you've done half the work for us, which is helpful for time. But yeah, I think those are the main things.
I think, from our side of things, I think 'cause in terms of blood tests that we request, inevitably, if I'm a duty doctor, for example, there'll be about 50 or 60 blood tests that come back on that day. I won't know 70% of those patients at all, or their story. So it'll come into my into my inbox effectively, and it'll just say white cells of 20. And I'm like, okay. I think most of us look at the trend. If it's like that for a while, then it's probably not anything that I need to act upon.
Service, I wasn't redeployed. Service was running as usual because the heme patients were becoming sick. I think the biggest thing was the effect on staffing, really. I think at one point we had 19 out of 22 nurses were off sick, so it was just crazy. But there's the thing I'm now seeing is the catch-up that everyone is now, and I'm sure it's the same for everyone, but the catch-up of, right, all these things need to carry on and we need to still see. I think there's 114 patients booked in for an afternoon clinic on Monday between three of us. It's only telephone, right? But I mean, it's a 7-hour job. So that's, I think, is the biggest effect. I think this, everyone has seen sick patients, but I think the way in which it just tore through people, or otherwise people that maybe our parents' age, was probably the most frightening thing.
I think we've all got sort of personal stories of people being affected. How does it change your practice going forward in terms of
the thing that's changed for me? And there's a comedian who actually posted a very good thing on Twitter about this, and he said, at a time like now, it's often better to be kind than right. And I think though you may be having that internal argument with ITU about why aren't you taking this 60-year-old who's otherwise well, or you're staying to renal, of course this is nothing to worry about, this is all reactive. Even though you're right, the way in which you portray that message to, you don't know how that person's day's been. That ITU reg may have created their 5th person, it's not even 10 o'clock yet. So I think though you may be right in your point, the way in which it can be delivered and the way in which it's presented is really important. And at the end of the day, I would say 90% of people, 95% of people working in healthcare are in it for the right reasons. And we are with, here comes the big soppy message, but we are all a team in it together. And everyone wants the best outcome for their patient, right? That's the main thing.
I think that's valuable advice anyway. Just it goes a long way if you're just nice. And people, their perception to you changes, and the entire sort of atmosphere changes, and then everyone's just happier. Just be kind. Okay. All right, Joel. Last question. What is the one piece of advice that you would have given yourself at the beginning of your career?
The best piece of clinical advice, I would say, is be involved in research early. Try it at university. Even if it's an extra year and you're going to be in a different year and you might not graduate with your friends, I would say seriously consider it. It's one thing I'm really regretting not doing. I think it's much harder to get into as a post-grad. So I would think try some research, try something. And the second thing that's non-clinical, I would give myself as advice, is be true to yourself and be sincere, because people can see through falsity. So don't act up as if you're something you're not. Just be true to yourself, be true to your background, and people should hopefully love you for
that. That is very valuable advice, I think, as a life lesson anyway. Joe, it's been great having you today, and I know you're busy, and I know
Thank you very much.
It's taken a lot to sort of get you on here today, but I really do appreciate you coming on. And I think that's a wrap today. I just want to say a big thank you for Joel coming on today. If you guys enjoyed the podcast today, we are trying to do this on a regular basis. So if there are any comments, suggestions, or if there are any specific requests for us to go forward, please leave a comment in the sections below. But otherwise, we'll see you in the next podcast.